We have a patient diagnosed with autoimmune hemolytic cytotoxic anemia. Autoimmune. What substances are antigen in type 2 allergic reaction? Obviously, you know that we have 4 types: type 1, type 2, type 3, type 4. So all of the asking us is what happens in type 2 hypersensitivity reaction. So in type 2 hypersensitivity, we also call it cytotoxic hypersensitivity. This is where antibodies produced by the immune system bind to antigens on the patient's immune cell surfaces. And these are found, or the surfaces, most of them are the cell membranes. The cell membrane. So actually, another name for finding all these substances, we call them what? A modified receptors. So the immune system sees this as what? A modified receptor on the cell membranes. And so therefore, it produces antibodies to react against it. So most of the antibodies reaction, this is what happens. The cell membranes are of what? Modified forms. So it sees it as antigen. So the answer is C. Your answer is C. Okay, look at this. Patient is suffering from hemorrhagic syndrome that shows itself in frequent nasal bleeding, post-traumatic and spontaneous intracutaneous and intraocular hemorrhages. Now look at this. Your main here is this. Your main clue here is it. Diagnosed with type B, hemophilia. You know of hemophilia A and hemophilia B. This is hemophilia B. Now in hemophilia A, we have what? Deficiency of what? Factor 8. Now in hemophilia B, we have deficiency in factor 9. So here we are thinking of what? A, factor 9. In hemophilia A, you could think of what? Factor 8. Okay, so this is factor 9. So A. How do I remember this? I know 8 comes before 9. So A, B. As simple as that. But you must know that we have 8 and 9. So 8 is A, 9, B. A 58-year-old patient suffers from cerebral atherosclerosis, which revealed increase in hyperlipidemia. That means increase in what? In fat. What class of lipoproteins will most probably show increase in concentration in the patient's blood serum? Now, definitely they're telling us what? Let's deal with what? Atherosclerosis, or the pathogenesis involved in atherosclerosis. And atherosclerosis is simply a disease in which a plaque made up of fats, cholesterol, calcium, and other substances are found in the blood. And they usually build up inside arteries. So a plaque is formed inside the vessels. And most especially, we deal with what? LDH. So LDH will transport cholesterol from the liver to the tissues, or from the liver to the blood. So when it transfers cholesterol, you know cholesterol is not good for the vessel. So as a result, reaction will take place, and eventually it start developing what? A plaque. So therefore, sometimes, in fact, we call LDH as a bad lipoprotein or lipoprotein. Bad lipoprotein. Then we have the good lipoprotein, also known as what? HDL, which transports cholesterol from the cells and tissues back to the liver. So it removes cholesterol from the cells into the liver. So we call it the good cholesterol. So people who develop atherosclerosis have a lot of bad lipoprotein, also known as LDH, low density lipoproteins. So the answer is what? B. In the course of preventive examination, a doctor revealed changes in the cardiovascular fitness, which was indicative of cardiac insufficiency at the compensation state. What is the main proof of cardiac compensation? What is the main proof of cardiac compensation? Now, when we say cardiac compensation, we are referring to what the mechanism or the adaptation that is being adapted by the heart to still maintain the function of the heart. I repeat, it is simply what the adaptation that the heart begin to evolve with or begin to adapt in order to still perform their function to prevent complications. That's what cardiac or in generally, that's what compensation really means. It's just like when you are feeling cold. What do? You get your blanket and you cover yourself up. That is what compensation. Now, in decompensation, even covering yourself up does not really work. So you begin to have signs and symptoms of decompensation. That means things you are still feeling excessive cold, like you are in the winter. Go outside without a jacket. You will see what happened to you. Exactly. That means your body will not be able to compensate for everything again. Great. So the question is that what is the main proof of cardiac compensation? And the main proof of cardiac compensation is what? Hypertrophy, where the ventricles will begin to hypertrophy. They begin to enlarge, to accumulate the fact that the heart is not able to pump the blood out. Because over here they say there is cardiac insufficiency, meaning the heart is failing, meaning the heart is not able to perform its function. As a result, the fluid there will do what? Will try to accumulate in the ventricles. And when it accumulates in the ventricles for far too long and it now enters into the decompensation state, we will start having what? Pulmonary edema. We will start having pulmonary edema. Pulmonary edema. So over here, we are talking about the compensation state. So here, we can easily go in for hypertrophy or myocardium hypertrophy. A 47-year-old with myocardial infarction, again, there's decreased flow of blood to the cardiomyocyte and was admitted. What changes of cellular composition of peripheral blood are induced by necrotic changes in the myocardium? What it means is that when there is infarction, and we said infarction means what? Inadequate supply of blood to the cardiomyocyte. Inadequate supply of blood to the cardiomyocyte. So the body begins to see this as what? As a problem. So when it's a problem, what will you do? It will send the agent to the place of what? And before that, when there is insufficient amount of blood, what happens? There's low amount of oxygen. And when there's low amount of oxygen, what happens? Necrosis will begin to ensue. Necrosis will begin to ensue. And this necrosis, the body will also see it as what? As a problem. So it's trying to come and give it oxygen, or trying to come and then supply blood to it. So it sees as an infection, as an antigen. So what happens? So usually it will lead to leukocyte infiltration into the place, or neutrophils infiltration into the site of injury, because that place is injured. So neutrophils will be the first to enter there. Then it will call the monocyte or macrophages, and then also the lymphocyte to come and help in the fight. So because it's an injury, there'll be neutrophilic leukocytosis. Neutrophilic leukocytosis, because that's the first inflammatory cell that enters the place of injury. So here we are looking at for neutrophilic leukocytosis. All right. A patient with skin mycosis has disorder of cellular immunity, When we say cellular immunity, what type of hypersensitivity are we talking about? Great. We are talking about type 4. Type 4. Type 4. Cellular immunity. Type 4. So the body typical characteristics of it is reduction of the following what? Index. Because they say the person having a disorder of cellular immunity. And cellular immunity is basically controlled by what? By the T cells. It's basically controlled by the T cells. So you're talking of what? T lymphocytes. T lymphocytes. T lymphocytes. All right. A patient with massive burns develop acute renal insufficiency characterized by significant and rapid deceleration of glomerular filtration rate. What is the mechanism of its development? What is the mechanism of its development? First, they've told you there's what? Burn. And then in burn, what happens? Look at it, massive burn. This could lead to what? Dehydration. Burn can lead to what? Dehydration. Dehydration. And look at it. As a result, there's what? Acute renal insufficiency. That means due to the decrease in the volume of blood, or perhaps the fluid in the body, it is leading to what? Kidney failure. And again, they are saying there's decreased glomerular filtration rate. So what happens? What it means is that there's a reduction of renal blood flow. Reduction of renal blood flow. Why? Because the patient is in a massive burn. Massive burn. So dehydration. Dehydration. Loss of fluid. Loss of fluid. And this loss of fluid can lead to decrease in renal blood flow. Decreased in renal blood flow. And as a result, there'll be decreased glomerular filtration rate. All right. Child is pale, pastors, muscular tissue is badly developed, the lymph nodes are enlarged. He often suffers from angina and pharyngitis. Blood has signs of lymphocytosis. Lymphocytosis. The child is also predisposed to autoallergic diseases. Autoallergic diseases. What type of diathesis can be presumed in this case? Now, I've already said a diathesis is a hereditary or a constitutional predisposition to a disease. To a disease. So, you being at risk to a disease as a result of hereditary is determined as what? Diathesis. Is determined as what? Diathesis. And of course, for us to have a lymphocytosis, definitely what kind of diathesis comes to play? You are definitely thinking of what? Lympho-hypoplastic. 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 So here, your answer is A. Lympho-hypoplastic. Lympho-hypoplastic. So your answer is A. And in some textbooks, you might see thymico-lymphatic. That's thymico or the thymos. So thymico-lymphatic. Thymico-lymphatic. They all mean the same. Patient of a 3-year-old child has been giving him antibiotics with the purpose of preventing enteric infection for a long time. A month later, the child's condition changed for the worse. Look at the blood analysis. There's leukopenia and granulocytopenia. That means low amount of what? White blood cells are being what? Produced or are seen in this what? Patient. Are seen in this patient. So what is the most probable mechanism? So the mechanism is that because of the frequent giving of antibiotics for a very long time, this could lead to a suppression in the bone marrow. Suppression in the bone marrow, also known as myelosuppression. Myelosuppression. That's MYE suppression. Myelosuppression or myelotoxic. 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 This is where there's a decrease in the production of cells responsible for providing immunity. That is what leukocyte or erythrocyte or even the clotting factors. When all of these things are under attack, So again, we are thinking of what? Of myelotoxic or myelosuppression or bone marrow suppression. Bone marrow suppression. So here we are thinking of D. Great. A patient is ill with enteritis accompanied with massive diarrhea. Again, if somebody is having massive diarrhea, what kind of electrolyte abnormality will you see? Yes, you will see what? Acidosis. You will see acidosis, excretory acidosis. However, that's not the question. The question is that he's having what? Low water rate in the extracellular what? Space. That means this patient is going through what? A dehydration. High water rate inside the cells and low osmolarity. Again, dehydration. So what is such disturbance of water electrolytic metabolism called? How is it called? So now when you have, so obviously I'm saying this is what dehydration, and dehydration occurs when the extracellular fluid and the sodium ions are lost. I repeat, dehydration occurs when the extracellular fluid and the sodium ions are lost. So now let's look at the different types in terms of osmolarity. Let's look at the different types in terms of osmolarity. Please kindly mute your microphone. Someone's mic is on. All right. Thank you, doctors. All right. So one, we have isoosmolar dehydration. Isoosmolar dehydration. This is based on a proportional volume decrease of fluid and electrolyte. Again, it is based on a proportional volume decrease of fluid and electrolyte. Example, acute renal failure, blood loss. So in blood loss, we have what? Isoosmolar, because the same amount of fluid that is lost, the same amount of electrolyte are also lost. So we call it what? Isoosmolar. Great. Now we have hypoosmolar. This is when there is salt deficit or there's decreased amount of salt. And this develops due to diarrhea. It develops due to diarrhea, due to vomiting, due to sweating, and then due to adrenal insufficiency. I repeat, hypoosmolar has to do with what? Inadequate amount of salt. And this occurs in diarrhea. So if you have diarrhea, you are excreting a lot of what? Salt. You are excreting a lot of salt. If you vomit, you are excreting a lot of salt. If you sweat, you are excreting a lot of salt. And if you have adrenal insufficiency, of course, sodium will not be there. So this person is having what? Diarrhea. So obviously, we could think of this as what? Hypoosmolar. What then is hyperosmolar? In hyperosmolar dehydration, there is deficiency of water. And this develops due to the loss of fluid which lacks electrolyte. Example is in diabetes insipidus and then in hyperventilation. I repeat, example is diabetes insipidus, where you excrete a lot of water. Then we have hyperventilation. So once again, we are talking about what? Hypoosmolar, because salts are lost more. So the answer is D. And I hope you wrote everything down. A patient with obliterating atherosclerosis underwent sympathectomy of the femoral artery in the region of femoral trigone. What arterial hyperemia was developed? Look at this. Underwent what? A cut of the sympathetic. A cut of the sympathetic, or a removal of the sympathetic. So what comes to play? Of course, paralytic. Paralytic. So this was neuroparalytic hyperemia. Neuroparalytic hyperemia. Again, sympathetic. Sympathectomy, meaning the removal of the sympathetic system. So here you are thinking of what? D. Good. We have a 15-year-old girl, is pale, glossitis, gingivitis. On the blood, we have 3.3. Hemoglobin is 70, quite low. Color index is 0.5, 0.5. And we said when color index is this low, what comes to mind? You are thinking of iron. You are thinking of iron. Iron. And again, there's what? Hypochromia, meaning there's no enough color. There's no enough color. No wonder hemoglobin is what? Is low. There's no enough color. All right. So here, what comes to mind? Iron deficiency. Again, check out for what? The color index. It's supposed to be around 0.9, 0.9 or 1, 0.9. But if it comes as low as 0.5, it means iron is deficient. Iron is deficient. Iron is deficient. So the answer is C. We have discussed this over and over. So please try and refer the notes or the videos. It will help you. Look at this. A 70-year-old man with vascular atherosclerosis of the lower extremities and coronary heart disease. Examination reveals lipidic blood composition. What is the main factor for atherosclerosis? I've told you countless number of times. Look, in terms of excess of lipoprotein, you are thinking of low density lipoprotein. Low density lipoprotein, because it carries cholesterol into the what? Into the vessels. The cholesterol on its own cannot move there. That is why it is not cholesterol. It is what? Lipoprotein, a low density lipoprotein. So please take note. Please take note. These densities carries the cholesterol. So either it carries it to the tissue or it carries it away from the tissue into the liver. So please take note. All these are all carriers. They are carriers. So the answer is what? Is A. We've discussed it already in our first presentation. A patient is ill with essential hypertension and had hypertensive crisis and resulted in an attack of cardiac asthma. What is the leading mechanism of cardiac insufficiency? Now, for there to have hypertensive crisis and for the history of arterial hypertension tells you that this patient is having what? Fluid overload. This patient is having what? Fluid overload or high blood temperature. High blood temperature. And high blood temperature, high blood pressure. High blood pressure. High blood pressure, not temperature, pressure. So this high blood pressure can lead to what? Fluid overload in the lungs. And this can lead to what? Cardiac insufficiency. Cardiac insufficiency. So over here, we are thinking of what? Heart overload caused by what? High blood pressure. High blood pressure. High blood pressure. Yes, you can be thinking of the increased blood volume. Increased blood volume. But don't forget, we are talking about what? They've already given you a clear history that this patient is having what? Arterial hypertension. That means there's high blood pressure. So this could be caused by too much of what? The pressure. Too much of pressure. But of course, if there's too much of pressure, definitely will be what? Too much of what? Of blood volume. But I don't know why they brought the two of them. However, the best one would be what? The high blood pressure. The high blood pressure, not the volume, the high blood pressure. All right. A 5-year-old girl is ill with measles. Blood analysis reveals what? Increase of total number of leukocytes up to 13. That means there's what? Inflammation. Basophils 0, eosinophils 1, myelocytes 0. Someone was asking about the neutrophil, another names for neutrophils. You see, we're having here juvenile neutrophils. They are all small or immature neutrophils. Band neutrophils. Now you see segmented neutrophils are also what? Are also there. Segmented neutrophils are also there. Now all these are quite okay. Lymphocyte. Now look at the monocyte. Monocyte is 28. Monocyte is 28. Monocyte is 28, and this is high. Monocyte level is high. In the normal blood, we're supposed to have about 3 to 11%. 3 to 11. 3 to 11. 3 to 11. So this is extremely high. So you can write these blood volumes down. Markers down. Or let me say leukogram values down. Normal monocyte is between 3 to 11. 3 to 11. Monocyte, 3 to 11. Then lymphocyte is between 19 to 37. 19 to 37. 19 to 37. That's for lymphocyte. 19 to 37. Neutrophils, 47 to 72. 47 to 72. 47 to 72 is normal. To 72. Eosinophils is from 0.5 to 5%. 0.5 to 5. Basophils is from 0 to 1%. 0 to 1. That's basophils. 0 to 1. And of course, leukocytes will be about what? 4.9 to, it's between 4 to 9. 4 to 9 times 10 to the power 9. 4 to 9 times 10 to the power what? 9 to the power 9. So over here, we are looking at an increase in the monocyte level, an increase in the monocyte what? Levels. An increase in the monocyte what? Level. You can also say there's what? Now, when we talk about agranulocytosis, we are referring to what? Lymphocyte and monocyte as well. Don't forget we have what? Granuloleukocytosis and agranuloleukocytosis. I know this is not something I'm supposed to mention, but then that's just by the way. We have agranular and one granular. And agranular, we are referring to what? The lymphocyte and what? The monocyte. All right. So here we have what? Agranulocytosis. But then the main granulocyte present is what? Agranulocyte present is what? Is monocyte. So we're talking of what? Monocytosis. Monocytosis. Monocyte develop into macrophages. In tissues, they are called macrophages. In blood, we call them monocyte. So just take note. In tissue, we call it macrophage. In blood, we call it monocyte. All right. Rat being under stress has muscular hypertonia and high arterial pressure, high glucose concentration in the blood, and intensified secretion of corticotropins and corticosteroids. In what stress phase are these animals? What stress phase are these animals? So this is actually referring to what? To anti-shock. Anti-shock phase. Anti-shock phase. And this is when compensatory mechanisms of the blood are activated to antagonize the devastating effect of shock. To antagonize the devastating effect of shock. That's what it's what? Increase in arterial pressure. And don't forget, in shock, we should be having what? A decrease. So this patient is what? In the anti-shock what? Phase. Because it's trying to adapt. It's trying to prevent the effect of the shock from happening. So it will secrete all of these things to increase the blood pressure. To increase the blood pressure. So here we are thinking of what? Anti-shock phase. In shock phase, meaning you have a shock. You have the shock. And in erectile, we say you have what? Excitation. You have excitation. We have excitation. So basically, that is just it. So here,
so please, the line was breaking.
Okay, I'm saying that in shock phase, obviously there'll be low blood pressure, and everything will be opposite. That is what shock phase. In erectile phase, we are referring to what? Excitation, which we discussed it earlier on. We are referring to excitation, whereby the guy is talkative and super active. Okay, that is what erectile stage. Erectile, but this is what anti-shock is preventing shock. Is preventing shock. Is preventing shock. So your answer is A. All right. Again, I'm seeing a question on alkalosis and acidosis, and I'm saying my students can never get this kind of question wrong. If you see this question, it's a bonus question. All right. After taking a poor quality food, a patient developed a repeated episode of diarrhea. Guys, diarrhea. So what kind of acid balance are you thinking about? Yes, you are thinking of what? Acidosis. 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 So even before we read, you know that this person is suffering from what? Acidosis. So what type of acidosis? I was telling you guys that we have what we call non-gaseous acidosis or non-gaseous alkalosis. It's the same as excretory acidosis, which should have been the correct one, either excretory acidosis or metabolic acidosis. Excretory, metabolic, or non-gaseous, they all mean the same. They all mean the same. So over here, we will definitely go in for what? Non-gaseous acidosis. Non-gaseous acidosis. So first of all, you have to establish that this is what? Acidosis. And if it is excretory, of course, whether it is metabolic mechanism, that means metabolism. So it can also be what? Excretory or non-gaseous. So your answer is A. A patient has been diagnosed with influenza, that's upper respiratory infection. His condition became drastically worse after taking what? Antipyretic. And you see, viruses, usually, they're not controlled by bacteria, isn't it? But the person took a medication, antipyretic medications, maybe paracetamol or something. But still, so it became worse after taking this, maybe paracetamol, maybe. Now his consciousness is confused. So now we're having what? CNS manifestation. Look at this: shock, 80-50, pulse, 140, body temperature has dropped to 35. That means the person is even what? Going shivering or begin to shiver. What complication has developed in this patient? What complication has developed in this patient? First of all, you must understand that antipyretic drugs, they block prostaglandin synthesis. They also block prostaglandin synthesis by inhibiting cyclooxygenase, that is COX. You know of COX-1 and COX-2. COX-1 and your COX-2. So they inhibit the cyclooxygenase enzyme, and again, these also play an important role in the regulation of temperature. They play an important role in the regulation of temperature. So over here, since the patient is going through all of these toxicity of this drug, it is resulting in what? In coma, followed by what? A collapse, and so on and so forth. So this person is actually having what? A collapse instead of what? Coma, because the person has not gone what? To coma, a full coma yet. Although the patient's consciousness is confused, he doesn't know where he is. That means he's lost. He's lost, completely lost. So this person could be developing what? A collapse, or could have. Yeah, the complication is what? Collapse. So here we are thinking of what? Collapse as the mechanism or the complication of taking the antipyretic drug. The antipyretic drug. All right. All right. So another dehydration question. A patient was admitted to the infectious department. I've already explained this question in another one, but it's a different question as well. So let's look at it. His symptoms: we have dry skin, decreased skin turgor, rice water stool. What it means is that we are having a dehydration. So the patient was diagnosed with cholera, of course, rice water stool, cholera. So what disorder of water electrolyte balance is most often observed in this case? So again, we are referring to what? Dehydration. Although we said in diarrhea Yes, the person has some diarrhea, but this diarrhea is not the normal type of what? Diarrhea that we saw in the previous question, where there is what? A decrease in salt. No, in rice water diarrhea, there's equal amount of decrease in water and salt. I repeat, in rice water stew, there's a proportional decrease in water and then in what? In the solute or in the salt. So we can term it as what? As iso, because there's equal amount of water and the salt are being what? Excreted. Are being excreted. So here we are thinking of what? Of iso-osmotic hypodehydration. Iso-osmotic. 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 So your answer is what? Is D. Your answer is D. I've already explained it. So if you have any question, please do let me know or do your best to watch the video again. So your answer is D. A 45-year-old woman has breast cancer. Her left arm has symptoms of lymphatic system insufficiency, lymph edema, lymph node enlargement. What form of lymphatic? Your question is what? Lymphatic circulation insufficiency. And over here, I think there's a lymph node enlargement. Lymph node enlargement. And they've told you a secret that is what? That's a cancer. Cancer. So what it could mean is that this cancerous breast or this cancer might have blocked the lymphatic system. It might have blocked the lymphatic what? System. And when the lymphatic system is blocked, there will be an impeded lymph flow. There will be an impeded lymph flow. And so therefore, we call this what? A mechanical insufficiency. Mechanical insufficiency, where there's what? Occlusion of the lymphatics by either cancer, thrombosis, whatever and whatever. Anything that is causing what? A blockage. We are referring to what? A mechanic factor. Mechanic. So here we have what? A, or obstructive. Mechanic or obstructive. They all mean the same. 25-year-old man has spent a long time in the sun under high air humidity. As a result of it, his body temperature rose. It rose. So what is the pathological process? It rose. It increased. High. So we have what? Hyperthermia. That's the term for an increase in what? In blood temperature. In blood temperature. So you're thinking of what? Hyperthermia. All right. Great. We've solved this question. 26-year-old man is in the turbid shock phase. We'll talk about the erectile phase. Now we have what? The turbid shock phase as a result of a car accident in the blood. What is the leading mechanism of leukopenia development? And we said in erectile phase, there's what? There is excitation, right? There's excitation. Then in the turbid phase, everything starts what? Calming down. So what happens in this case is that, or what is the cause of the leukopenia in this development? So basically, there is what? A redistribution of leukocytes. We discussed it earlier on. We have already discussed it. We have already discussed this. So we have a redistribution of the leukocyte leading to what? To leukopenia. Because the blood will say as well, there's leukopenia, but actually there's what? Leukocytosis at a particular kind of what? Of place where there's no enough what? Blood there to sustain the body, or it serves as a compensatory what? Mechanism. Serves as a compensatory what? Mechanism for the body. So here we are looking out for what? For a redistribution. So here, that is our answer. Redistribution.